vestibular ataxia, when there is loss of balance and coordination due to the vestibular system malfunction, where there is extreme dizziness, vertigo, and oscillopsia, and cerebellar. And rarely there is a situation called optic ataxia, which is a different kind of a problem which arises from the parietal lobes. Okay. Slide. Am I audible? Okay. This is just an illustrative example of a patient of mine to show how disabling situations can be. And this is, as in all branches of medicine, these are the pitfalls quite commonly, not very commonly, but occasionally we come across functional ataxias, which you need to differentiate from the organic ones before jumping into number of investigations. So anyway, next slide. Yeah. So a few relevant examinations help us to come to a diagnosis of the kind of ataxia. When it's a sensory ataxia, a peripheral neuropathy in the form of a glove and stocking sensory loss, or a dorsal root ganglion problem, where there is a profound sensory problem with the spared motor system and loss of reflexes, loss of posterior column sensation, vibration, and joint position senses, along with occasionally myelopathic situation where the spinal cord is involved, but there is a sensory level. So all these are associated with a normal speech that helps to differentiate from the cerebellar ones. Now, vestibular malfunctions are very much prominent. Vertigo is there, along with the positive head impulse test, and there is a nystagmus, which is of the vestibular type. That means it reduces with fixation. Here also the speech is normal. Unlike the cerebellar ataxia, where the speech is grossly dysarthric with irregular cadence and volume, while the limb is dysmetric with dysdiadokinesia, past pointing, and tremor, which is intention tremor type. That there is a prominent nystagmus usually with square wave jerks and other dysmetric subparts. Now, next slide. Now, four factors. Now, there, as it is very obvious by now, there is a huge number of differentials in this kind of, or causes for this kind of problems. So, to home into a particular cause, one of the important factors, there are four factors mainly we use to diagnose. One is asymmetry of presentation, where structural problem of the cerebellum is usually considered like intracranial swells or demyelination or stroke. Occasionally, there are structural congenital malformations. Neuroimaging comes to the rescue to identify them. Age of onset is another clue, where age of onset is another clue, where a childhood onset problems usually points to a congenital problem, an intrauterine injury or viral infection, which is common in children. Adolescent presentation is usually found in Friedreich's and other autosomal recessive. Occasionally, younger patients also present, but most autosomal dominant usually develops earlier. Usually, by 20 years, they are already obvious. And old age, it is variable. You can get usually the acquired causes. Occasionally, some familial causes can present in old age also. But most important clue comes from the acuity of presentation. That means whether it is an acute presentation, subacute presentation, or chronic presentation. Next slide. Next slide, please. Now, the presentations can be symmetric or it can be asymmetric. Now, symmetric presentations are usually, when they are acute, they are usually due to intoxication like lithium or drug-related problems. Alcohol is a very common culprit. But in children, very commonly we get acute viral cerebellitis, which comes with a very hyperacute and explosive presentation. And of course, there is a post-infective situations, immunological situation like demyelination. Uh, there are subacute onset also, where also drugs and intoxications, especially people sniffing glue, which is a common practice in our society and a certain sector. And cytotoxic drug, chemotherapeutic drugs, they can produce cerebellar damage in a subacute fashion. But immune mediated problems are a very important issue here, where multiple situations, of course, multiple sclerosis is there, demyelination. Along with that, peripheral nervous system problems like Guillain-Barré syndrome, especially Miller-Fisher syndrome, presents with ataxia with ophthalmoparesis. Paraneoplastic Lambertiton peripheral neuropathy, Lambertiton type, can and very frequently have cerebellar dysfunction also. Along with that, gluten ataxias, celiac disease with gluten ataxia, can also present in a subacute and chronic fashion. And there are other non-organ specific autoimmune diseases which can involve the cerebellum frequently. Now, chronic and symmetric ones are usually the heredofamilial groups with inherited diseases. And however, one should not forget hypothyroidism and other autoimmune disease like antigliadin syndromes, the celiac disease, and gluten ataxias can present in the chronic way also. But one important pitfall is to miss Davis dorsalis, which is not very common nowadays, but occasionally we find cases. The other group is focal cerebellar situation. These can also present in an acute, subacute, and chronic way. The acute focals are usually vascular problems, infarct, hemorrhages, and other assaults on the cerebellum, while infective causes can also be there. While subacute presentation with focal cerebellar affections are usually demyelinations and AIDS related or PML, that is progressive multifocal leukoencephalopathy, and there must be neoplastic gliomas and astrocytomas, which can present gradually in a focal way. Now, chronic cerebellar, which is focal, are usually due to gliotic scars or other vascular lesions. Prion disease can present in the chronic way, and there are certain congenital cerebellar malformations which can be chronic and focal. Now, next slide. Next slide, please. Now, next thing we have to look, I think this should be given after some year because some who is controlling the slides. This should be come after a click. Anyway, I'm using the arrows. So this kind of a pes cavus can point to a Frederick ataxia problems. This can help to localize to the diseases. While on examination of the eyes, this kind of a blush of vascular markings can point to an ataxia telangiectasia syndrome. One should not miss a swelling of the tendo achelis, which is pointed towards the cerebrotendinous xanthomatosis, which is a treatable condition. Early onset cataracts not only points to some rare diseases like Marinescu Jogren, but one should not miss Kesha ring or KF ring, so that Wilson disease, which is a potentially treatable condition, should not be missed. This kind of fundal examination showing ectal, here I think it is not visible properly. However, ectatic blood vessels can point towards a von Hippel-Lindau syndrome, which is a multisystem disorder presenting with cerebellar problems occasionally. And this picture is of a xeroderma pigmentosa, which can come with cerebellar situation, and it is a potentially preneoplastic condition. Next slide. One should not miss this kind of skin rash in a cerebellar disorder, which is pointed towards niacin deficiency and Hartnup disease, which can commonly present in children with cerebellar ataxia. And this is a pellagra rash. So this rash points to an underlying metabolic disorder. Next slide. Next. So associated findings can also be pointed towards the disease, like autonomic failure is multisystem atrophy, underlying or prominent malignant disease, paraneoplastic disorders. A history of malabsorption is always should be taken to rule out gluten ataxia and vitamin E deficiency. Severe sensory symptoms are found in Friedreich's, and peripheral neuropathy is found in a lot of heredofamilial diseases like the SCA and the CTX. Visual symptoms are prominent in SCA7 and vitamin E deficiencies, while tremors are common in Wilson's disease and Fragile X tremor associated syndrome. So these kind of associated findings can be helpful to identify or home in into a diagnosis. Next slide. Now, potential tests to identify the disease like hemograms, Hemograms other than the common things. Next slide. Please click. Next slide. Yeah. So, peripheral blood may show this kind of anemic blood picture with hypersegmented neutrophils and macrocytes, where vitamin B12 can be a culprit. This is the slide. While occasionally acanthocytes can be prominent, which can point towards an underlying vitamin E deficiency. A lipid profile abnormality like reduced cholesterol or triglyceride occasionally might point to an A beta lipoprotein problems, which is confirmed by electrophoresis, lipoprotein electrophoresis. A complete metabolic panel, including the liver functions and most importantly, thyroid, should not be missed. A vitamin E blood level and vitamin B12 blood level and copper should be tested. Now, the second line tests are usually guided by the clinical phenotype, like CSF analysis is usually done to confirm tevis dorsalis. Lactates are done for the mitochondrial diseases. Autoimmune panel should include the anti-transglutaminase or anti-TTG2NSX. Those are usually done to rule out the gliadin-related problems, that is the gluten ataxic problems, which are treatable by diet restriction. While anti-GAD65 antibodies help to rule out some diseases which has a overlap with the stiff person syndrome. They can have some ataxia, cerebellar ataxia. Now, Lyme disease is identified by the calcium channel antibodies, and there is a panel for paraneoplastic antibodies. Now, heredidometabolic disorders are usually not very common. Next slide. Next slide, please. There is a long list of hereditary disorders like Hartnup disease, maple syrup urine disease, which require specialized tests. I'm not reading out all of them. Refsum disease, those are relatively rare, but occasionally they can be done. Next slide. Now, MRI comes to the rescue of many diseases like hemorrhagic cerebellar infarct. Please click infarct. Cerebellar infarct can be ruled out very easily. These are not very uncommon, but please next slide. I think the clicking must be with me. Anyway, so occasionally a very subtle abnormality like Chiari malformation can be missed. And here is the small Chiari, which is not very uncommon, but can be missed. Next slide. This kind of Joubert syndrome with the molar tooth appearance of the vermis can occasionally missed. Next slide. A multiple sclerosis is a very common one we can find very often. But next slide. A bilateral MCP hyperintensity points out to a diagnosis of fragile X tremor ataxia syndrome, which is occasionally can help, although rare, can help to clinch the diagnosis. Next slide. This is a hot cross bun sign in MSA, which is non-specific but is common in the MSA group. Next slide. And occasionally, rarely though, the MRI can help to diagnose prion disease. So MRI, to a lot of extent, not only rules out structural abnormalities, but occasionally generalized cerebellar disorders can be identified by neuroimaging. Next slide. Next slide, please. So next big group is the heredodegenerative ataxias, which can be autosomal dominant like spinocerebellar ataxias and DRPLA and episodic ataxias. While autosomal recessives are usually the Friedreich ataxia, the most common inherited disorder, and there are a host of DNA repair diseases like ataxia telangiectasia, etc. Wilson disease, vitamin E deficiency, refsums are the others. There are few X-linked diseases like fragile X tremor ataxia syndrome and adrenoleukodystrophy, and the few mitochondrial disorders present with ataxia like MARRF, NARP, and Leigh syndrome. That is myoclonic epilepsy with ragged red fibers. Next one is the neuropathy, ataxia, retinitis pigmentosa syndrome, and Leigh syndrome. These are the few mitochondrial diseases which can present with ataxia. Next slide. So, genetic testing is the talk of the day. These genetic diseases are almost very difficult. They are notoriously difficult to distinguish on clinical grounds alone because of broad clinical overlap, and usually a battery of genetic tests is done to identify the disorders. The mode of inheritance, as I said, autosomal dominant, recessive, X-linked, etc., helps us, along with some key clinical features, helps to narrow the list and point out to the genetic tests occasionally. Next slide. So these are the almost a few clues which can be helpful. Like SCA1 may show some extrapyramidal features. SCA2 slow saccadic eye movement. SCA3 may have some perioral fasciculations or tongue fasciculations. SCA7 may have visual problems, so on and so forth. But they are not always that easy to find and point out to the genetic abnormality. So for the spinocerebellar ataxia group, now it is more or less a purely genetic classification based on the genetic loci. Almost 30 or more than 30, almost 40 loci abnormalities are found now, and more are coming day by day. So commercially available screens are there, but they are still they are about to find lot of ataxias are still now not identifiable by those panels, and when occasionally exome genome sequencing may be helpful. Next slide. Now, this is just not a comprehensive, not a very comprehensive list for treatable ataxias. Vitamin E supplementations around 800 milligram, quite a high dose, is required for patients with vitamin E deficiency in A beta lipoprotein patients. And in cerebrotendinous xanthomatosis, chenodeoxycholic acid supplementations can help halt the progress of the disease. Some disease, you advise restriction of the plant proteins, etc. But most importantly, gluten ataxia or celiac sprue related problem. There you see you advise a gluten-free diet, and of course one should not miss the immunological causes where immunosuppression with IVIG and corticosteroids in multiple cases can be helpful. Recently, there are reports of IDBinone being helpful in Friedreich's ataxia.